Hi, and welcome back to the Mastering Your Fertility TV. You're watching episode 32, where we are interviewing Dr. Lora Shahine, a reproductive endocrinologist out of Seattle, Washington. She works at the Pacific Northwest Fertility Center, where she also opened up a specific center for recurrent pregnancy loss. And the reason why we sought out Dr. Shahine's awesome knowledge is because she published a book 2 years ago called Not Broken, which is an approachable guide for couples that are dealing with miscarriage and recurrent pregnancy loss. So in today's episode, we talk specifically about this topic, and you're going to learn the most common causes of recurrent miscarriage, also the correct definition of recurrent miscarriage, and the first steps in evaluating the potential cause. And then also some things that you can do to reduce your risk factors going forward. And so she's very approachable and gives us some actionable steps to be able to feel like you're more in control of this journey of yours. We also touch on a few other topics because we went on a couple tangents along the way. And so you'll also learn some common fertility myths to watch out for. The downsides of freezing your eggs. So we think it's wonderful, but there are also some downsides that we don't think are talked about enough out there. And then also why IVF isn't always the best answer. So it's jam-packed with really valuable information. And Kristen's just going to let us know a little bit more about the episode and read Dr. Shahine's bio for us.
Yeah, this was one of my favorite podcast interviews that we've done. I really appreciate her openness to integrative therapies. She actually recommends acupuncture therapy. She has an acupuncturist that she works with and frequently refers patients to. And she's very open to the diet and lifestyle side of things and the success of those natural therapies to support a couple, whether they're going through IVF treatment or they're not. And, we did mention that we talked to her about why IVF isn't always a fix-all treatment for every situation. And I think that she is really open with her patients about their possibility of success with conventional treatments when it might actually be just as successful to try naturally as trying through IVF. And I love providers like that are really considering each individual situation and not recommending just like a standard protocol type of treatment to every couple that's experiencing infertility. She's really willing to investigate root cause with couples, kind of using the best of integrative medicine as well as Western medicine to do that. And so she's a great resource. I'm very excited that we got the opportunity to talk with her. So I think you guys will really enjoy the episode. And her book is, very fun. And her book is really amazing. That is an incredible resource because she really goes through what we have evidence for, what testing and what treatments can be looked at in what situation. I think it's written very compassionately, especially for women or couples who may have experienced multiple losses already. And it's really emotionally intelligent, but also very science focused, and also easy to read. It tells you everything that you need to know, but it's not written in a way that's intended to be over your head or that only your doctor could interpret. So fantastic resource for anybody who may be struggling with loss, as well as anybody who just might want to prevent loss. I mean, there's especially from the diet and lifestyle perspective. Everybody.
Right.
But if you have any specific fears about miscarriage, I think some women who have been through infertility for a long time, when they finally get pregnant, there's like that fear that you're not going to be able to maintain the pregnancy. And so I think there's a lot of really amazing information in there as well, even just from the diet and lifestyle perspective, as opposed to specific investigations for miscarriage. So very big fan of her book, Not Broken. So I will go ahead and read her bio, introduce her to you guys, and we'll get right into the interview. So Dr. Lora Shahine is a reproductive endocrinologist currently practicing at Pacific Northwest Fertility and IVF specialist in Seattle. Originally from North Carolina, Dr. Shahine graduated with a Bachelor of Science in Biology from Georgetown University in Washington, D.C., and completed her training in medical school at Wake Forest University School of Medicine, residency in obstetrics and gynecology at the University of California at San Francisco, and fellowship in reproductive endocrinology and infertility at Stanford University. As clinical faculty at the University of Washington and director of the Center for Recurrent Pregnancy Loss at Pacific Northwest Fertility, she is committed to providing excellence in patient care, teaching the next generation of women's healthcare providers, and continuing research in the fields of fertility and recurrent miscarriage. She has published over 50 peer-reviewed research projects and is an active board member of the Early Pregnancy Special Interest Group of the American Society of Reproductive Medicine, Seattle Gynecology Society, and the Baby Quest Fertility Grant Organization. Dr. Shahine is an accomplished author of her own blog and 3 patient-centered books on integrative approaches to fertility care and recurrent miscarriage, including her best-selling book, Not Broken. She's passionate about patient education and changing the conversation surrounding infertility and miscarriage from one of shame and guilt to one of support and empowerment. You can learn more on her website, which we will have in the show notes for the episode, which is on our website, tinyfeet.co/podcast. You can find all of that under episode 32. You can also connect with her on social media at Dr. Lora Shahine on Instagram, Twitter, and Facebook. We hope you enjoy the interview.
Hi, welcome, Dr. Shahine, and thank you so much for being part of the fertility podcast today.
I'm excited to be here. It's an honor.
Awesome. Yeah, we are so excited to have you. So first of all, tell us a little bit about your background and how you became a reproductive endocrinologist working in the facility up in Seattle.
Absolutely. So I always knew that I wanted to be a doctor, although nobody in my family is a physician. It's just something I was always drawn to. And in medical school, I loved everything that I did. And finally, my last rotation was obstetrics and gynecology. And it's just like a light bulb. Women's health, a little bit of surgery, delivering babies. It just seemed fantastic, a great fit. And through the 4 years of OBGYN residency, just absolutely loved it, but was introduced to the field of fertility. And it really combined a lot of my passions, really helping people at a really vulnerable time. All the technology, I just knew that I would never stop learning. And just really being able to help people build their families. It just seemed like a great fit for me. And I'm very fortunate that I got the fellowship in reproductive endocrinology. And in looking for a good fit, I just found this incredible practice in Seattle, Pacific Northwest Fertility. It just combined so much of what I wanted, putting patients first. A smaller practice. I would be the third doctor. Really a physician-owned practice. So being able to make decisions based on what we thought was right for the patients is very empowering. And so, I could talk for hours about it, but that's the Cliff Notes version.
I love the passion, for sure.
Yeah. And when you were at is it Stanford that you did your residency in? Was it fellowship as well? Or
So I did the OBGYN residency at the University of California in San Francisco. That was the 4 years of delivering babies. And then my fellowship in reproductive endocrinology was at Stanford.
Great. Okay. And then is that when your mentor opened up a recurrent pregnancy loss center?
Exactly. So I was in the right place at the right time to learn something really interesting and a unique way of looking at trying to learn about a problem that we still are learning a lot about, is a humble way to put it. So my mentor, Ruth Lottie, who is still at Stanford, and she's now the residency and fellowship program director, she decided to open up a center for recurrent pregnancy loss while I was there. So I learned a lot being in the right place at the right time. And what I really appreciated was her collaborative approach in gathering experts and interested parties from lots of different fields, basic science, immunology, gastroenterology, of course, obstetricians and high-risk gynecologists, just because with how much information is out there, we really can't read every single study. And a complicated field like women's health, reproduction, miscarriage, there's so many components. I loved just bringing these people together.
And you loved it so much that did you open up your own center up at Pacific Northwest fertility.
Right. And that was not something that I was planning on, I would say. I started my practice at Pacific Northwest Fertility and just really enjoyed the first year taking care of fertility patients and learning how to, you know, be, my own, you know, I guess I've been taking care of patients since medical school, but it's different when you're the attending and you're making the decisions. And so really enjoyed that. And I kept seeing people that had multiple miscarriages and realizing that there really wasn't anyone in the area that was really focused on it. There are several reproductive endocrinologists, but it's not something that a lot of people focus on. And I realized that I had a unique background and talked to my partners and said, this is something that I feel really compelled to do. I was actually reluctant and quite nervous. I felt like it was a huge responsibility because I certainly don't know everything. But the fact that I had that background and that I cared and that I was willing to continue to learn, it was a big leap of faith on my partners and myself, but never looked back. I'm glad I did it.
We're glad you did it too. And so that led you to writing a book, right? Well, your first book was setting the seeds to pregnancy. Did I say
Yeah.
that
Like,
right?
I fell into writing sort of accidentally too. So the very first person that referred a patient to me when I moved up to Seattle and started my practice in 2009 was an acupuncturist, and her name is Stephanie Gianarelli, and she's a fertility acupuncturist and had her own practice in Seattle. And I came from San Francisco and the Bay Area, where there's definitely more of a balanced and integrative approach, but this is a long time ago, and that was still pretty wild for an acupuncturist to refer to an IVF doctor. I put in air quotes. And so I picked up the phone and started talking to her, really built a friendship, and we've shared a lot of patients through the years. And she had been working on a book, Planting the Seeds of Pregnancy, really trying to discuss an integrative approach, or excuse me, she was really doing a traditional Chinese medicine approach to fertility and trying to explain just the vocabulary is different, but we're all trying to do the same thing. The healthier we are, the more balanced we are, the more receptive we are to getting pregnant, and trying to make it a readable thing for an audience that's, Western comfortable. And she's like, I just really want somebody else to write a little bit more about the Western approach, what to expect if you go to a fertility doctor, and what is an intrauterine insemination, and how is IVF different. And so I was like, okay, I'll write a chapter. And that turned into another chapter, another chapter. And it really became a collaborative approach. And we ended up publishing. And so that was my first delve into being an author. And I really enjoyed it. And then after 5 or 6 years of the Center for Recurrent Pregnancy Loss, I published a lot of academic papers, but I just found that I kept saying the same thing in consults. It was to different people, and every interaction with the patient is different, but I kept saying the same thing. I kept doing the same tests, and the nurses were reporting and patients were reporting, they were asking the same questions over and over again. And I was like, if I wrote this down, I think I could actually make this easier for people. And so it started off with a couple blog posts here and there. And, I was like, well, I've actually published a book before. So that came out. And the way it works in the practice, I actually, I give it to every patient that I see. And that's what it's designed for. It's supposed to be able to say, there is no way that you are going to retain everything that I say to you in an hour. So we're talking on a high level, but if you want to delve into the things that we're talking about, here you go.
I think it's such an amazing resource. I mean, I read the entire thing cover to cover, and I was just kind of blown away by just how much information you provided and the different perspectives that you offered. And I think that's really helpful for patients, and talking about the integrative side of things and some of the ways that patients can support their health. It's not all just about like, oh, you have to treat this way. It's these are all the different ways that you can support your health that will help you, be more confident on this journey and just make the whole process better and easier. So I really appreciated what you did with Not Broken.
Thank you. I really appreciate that. I think it took me a long time of disappointing a lot of patients or getting comfortable with the unknown and sitting across from somebody time and time and time again who is looking to me for an answer. Why am I having miscarriages? Why is this happening to me? I am broken. Fix me. And realizing that I don't have to have all of the answers. This is what we have. This is what we are learning. This is what we need to know in the future, but I can still give good care. And I think it's one of the reasons a lot of people, physicians, especially Western trained physicians, don't really focus on miscarriage. There's not a lot of answers, and it's a very uncomfortable place to be when you go into a field to fix people. It's much easier to diagnose high blood pressure, give a prescription, and see them again later. I mean, we should really focus on lifestyle issues in that factor as well. Um, but I do appreciate your noting that I do really talk about a lot of different approaches because, as you know from the book, I'm not doing like high dose steroids or intravenous immunoglobulin or intravenous intralipids. And it took me a long time to be able to feel confident in talking to patients about that because, gosh, so many people, they just want to do something. And doctors just want to do something. And there are real side effects with those things. And it's hard to explain. Um, it's not that I'm not doing something for you. I'm trying to, keep you safe. And I just want you to learn about all the different options and not just do something that really could cause harm.
Yeah, I mean, you talked about this area of medicine as like a kind of a big gray area. There's still so much that we don't know. And it's hard because there's a lot of information out there that women are coming across from different avenues. And, you do kind of have to be in that position where you have to make a decision about what you're going to kind of entertain in terms of treatment in your practice based on the best available evidence that we have right now. So I think you did a really good job of kind of walking the line and talking about some of the therapies that maybe you don't necessarily support based on the evidence, but at least acknowledging that those are there and talking about some of the risks and the benefits to those things. So
Mhm. And I do have patients that do still seek that treatment. I don't prescribe it, and I just talk to them about how I feel. But it, if they're doing it, I'm saying just let's be honest, because the worst is when the patient gets stuck in the middle where they're kind of going between different providers and might not tell their Western medicine provider that they're doing, say, acupuncture, which is not one of the controversial things that we're talking about, but they're just they hide what they're doing, and I think that's the worst because if we don't know, then we can't talk about it.
yeah, and I think it's important also to, have that very open, very supportive relationship with a provider. And I want to talk about that a little bit more kind of towards the end about how you recommend women and couples choosing their care team. But for now, let's kind of jump into the subject of miscarriage a little bit more. So can you start off by telling us what the difference is between a biochemical miscarriage and a clinical miscarriage?
Sure, it's just basically how far along the pregnancy gets before it stops developing on its own. And the difference between them is very important in academic papers and for medical records. And we do, think about them differently. And as far as like definitions, it's important. But I think there's definitely a difference between, clinically and what we think about it medically and in textbooks and what women feel. And that's really important to note. So, a clinical miscarriage is a pregnancy that stops developing on its own after the point where you can see something on ultrasound or you can have a tissue diagnosis. And so, in general, that's about 5.5 weeks and further, because even at about 5.5 weeks, you can see a gestational sac on ultrasound. So if you can see something on ultrasound or somebody has a DNC or they have tissue that they bring in, it can be tested. That's considered a clinical miscarriage. Whereas a biochemical miscarriage, there's a positive pregnancy test, either a home test or a blood test that definitely says that the pregnancy hormone is, being made by the body. There is implantation, but it stops developing before you can see anything on ultrasound. And so, it's kind of, it's a gray area. If someone's had ultrasounds, it can be very clear. Sometimes people, they find out that the pregnancy stopped developing when they are 10 weeks along. They haven't had a period in 10 weeks, but yet, you know, and there's been no bleeding, but there's nothing on ultrasound. So that's technically a biochemical miscarriage. Does that make sense?
Yeah.
I said that very.
You call that miscarriage?
Um, well, if there's something on ultrasound, and the person hasn't started bleeding or passing any tissue, but there's no heartbeat, or the pregnancy, you can do an ultrasound and then a week later there's no change or no development in that week, but yet again, there's no signs of miscarriage like bleeding or cramping, that's considered a miscarriage.
Mm-hmm.
And actually, they say missed abortion if you really want to get to the medical or what you'd read in a medical chapter book.
Right. Yeah, I wanted to clarify that too, because in the medical research, we talk about spontaneous abortion or missed abortion, and that could be really triggering for women when they don't understand that we're referring to miscarriage. And so could you just touch on that a little bit?
Sure. Abortion is just a pregnancy that stops developing before, or let's say a pregnancy that stops, no matter whether someone initiates that pregnancy to stop or it happens naturally, but a pregnancy stops before usually 20 weeks, or some people say before a live birth. Okay.
Mm-hmm.
And in lay terms, we think of abortion as a pregnancy that's stopping because somebody's taking an action, whether they're taking a pill to induce cramping or whether they have a procedure called a dilation and curettage, or DNC, to actively stop a pregnancy developing. But if a pregnancy develops or stops developing on its own naturally, we refer to it as a miscarriage. But even on on bills from medical insurance, it'll say the word abortion, because that's how the terms are, listed when you're a doctor and you're having to check off these codes. And somebody talk about a trigger, they get the medical bill and it says, missed abortion. And they're like, I didn't have an abortion. And it's just, I feel so.
Oh, how many times you had to clarify that with patients, I'm sure.
Well, it's good that you went over that in the book and discussed the difference and explained that and acknowledged that that might be triggering for some patients.
Yeah.
So we definitely won't be able to go into all of the causes of miscarriage, but can you talk about some of the ones that we know of from research?
Sure. The most common cause of a first trimester miscarriage is a chromosomal imbalance in the pregnancy itself, just the way that particular egg and sperm came together, and the chromosomes, there's an extra chromosome or missing one. So if you're able to test pregnancy tissue for this, depending on a lot of factors, anywhere from 60 to 80% of the time, you will find that that is exactly why the pregnancy stopped developing on its own. It's a genetic issue that has nothing to do with the people that are getting pregnant or stress or wine or intercourse or all those things that people worry about. It's really something that happened at fertilization. And, we've learned so much in studying genetics, and especially in the field of IVF and the ability to screen embryos for chromosomal information before you transfer embryo. And human reproduction, this sounds really weird, but it's so inefficient. Like, there are so many of the embryos that we make are not going to be babies. And that doesn't take away the physical pain or emotional pain of going through a miscarriage or a loss when you are so ready to add to your family. But that really is the reality of getting pregnant.
Yeah. It is,
Yeah.
unfortunately. But I
Yeah,
mean, it's good to know that the odds are still really in your favor for the next time around after a miscarriage. That doesn't necessarily help to hear like, oh, just keep trying, it'll be fine. But it is good to know that the statistics are in your favor for a successful pregnancy the next time around after a miscarriage.
absolutely. Every pregnancy is a new opportunity and a great study that will never be able to be repeated again in the same way from Brigham, and it was published in the 1990s. Just looking at age and how many times someone had gotten pregnant, and no intervention whatsoever, no aspirin, no progesterone, no IVF, just what happens with the next pregnancy if they just are able to try again. And even at that point, if someone was 40 years old and they'd had 5 miscarriages, the sixth time that they conceived, 50% of the time they had a baby.
Those are pretty good statistics. I mean, especially given the history there.
Absolutely.
Right.
So
And
it's
the
so
age.
good.
Yeah.
Yeah, it's so good that we are getting information out there that, 1 in 4 pregnancies will end in miscarriage, and age is a huge predictor of miscarriage and difficulty starting your family. But there's a tipping point where we're, almost talking about it without positive facts. So women are coming to me in such fear, like, oh my God, age 35 is this like cliff. And if I don't have my family by age 35, I never will. And I'm like, yeah, okay, all right. Yes, fewer of the eggs are perfect after age 35. The miscarriage rate does go up, but most people have their families just fine after 35, so it's kind of, there's got to be some balanced information out there.
Yeah, I wanted to ask you about some common misconceptions when it comes to fertility. You just mentioned one of them, and also what you kind of hear in the fertility clinics. Why people end up there, and what are some misconceptions?
Absolutely. Those are fun. I try to do a fertility myth every Friday on my Instagram account. And it's just been really fun and informative because I get lots of people messaging me ideas. So some of the most popular ones are if I've had a baby before, and this is especially for men, if I've fathered a pregnancy before, then there's nothing wrong with me. I don't even need to do a semen analysis. Like, I'm all good, right? Um, and another one is my family's fertility history is going to be my story. So if my mom, had babies in her 40s, then I will be able to do that too. Or my sister, gets pregnant at the drop of a hat. I haven't tried yet, but I'm not worried about me because everybody in my family is fertile. Um, some other ones are, that miscarriage is my fault, right? That it's me. I'm broken. That it's something that I'm doing wrong, or it's my immune system that's rejecting a baby. When in reality, it's almost always an embryo issue. So those are top 3, and there's just millions.
Yeah.
That's definitely true.
I know you mentioned on another podcast I was listening to about women thinking, this is wonderful, but the idea of like, oh, we can start freezing our eggs. And I know that we can. And like I said, how awesome that science is advanced enough to be able to freeze our eggs. But you did mention that like that there's definitely some side effects to freezing eggs, or maybe science just isn't quite there yet as much as we think it is.
Yeah, that's if you're just paying attention to social media or reading People magazine, it seems like it's easy and 100% successful and a guarantee. And I am a huge proponent of egg freezing, and I do think it is an incredible technology. But I think people should be very, very well counseled before they do it, because it is not a guarantee and it's not 100%. And people, um, make it an empowering choice, but it's just it's a backup. I worry about people making huge life decisions based on having some eggs in the freezer, because when they, there's a whole generation of women that right now are the pioneers, and we've got some data, but most people who have frozen their eggs haven't used them yet. And so it's really going to be 5 or 10 years from now when we really realize, how it works. And again, huge proponent, but it was, the first baby that was born from a frozen egg was 1986. So you're like, oh my gosh, this is old technology. This is great. But you know what? That was a miracle. And it was really, really, really hard to replicate that. And it wasn't lifted as an experimental procedure label by ASRM until 2012.
Oh,
And
wow.
now that's
Relatively
7 years,
new.
but that's,
Yeah.
in my lifetime. Um, and I think it's really important. So my clinic is really unique in that we've been freezing and using eggs since 2009, but the majority of them are with our donor egg bank. And so these are like 25-year-old eggs. And we even see that different people, even if they're the same age, their eggs freeze and thaw and work differently. So even when you give somebody statistics based on, oh, you're freezing your eggs when you're 32, this might be based on a couple of hundred people that have come back to use them. But we still have a lot to learn. So again, huge positive, wonderful thing. But if you really want me to get up on my soapbox, I think we've got to find a way to help women have babies when their bodies are ready to do it, not just kick the can down the road. It's so hard for women because, your most fertile years are your most like career building years. And, like the physicians have a huge rate of infertility because they're waiting, because they're doing residency and fellowship. And I'm a great example of that, waiting and waiting and waiting to have a kid. So anyway, you didn't ask all of that, but I could talk for a while on that
Oh,
too.
that's great. I'd also like to ask about IVF because I think a lot of women and couples sort of view IVF as like the ultimate, fertility treatment, but it's not necessarily right for everybody. So can you kind of talk about that a little bit?
Oh, absolutely. I know. I'm a IVF doctor that often talks to people about not doing IVF, because it's not a perfect treatment for everyone. Um, People really do hold it up on a pedestal. If it's this most advanced technology and it's certainly darn expensive, it's just got to work. And again, you're kind of, I think because people are talking about it so much, they sort of feel like everybody else is doing IVF and it's got to be working for them. So people almost are a little bit flippant about it, more than when I started practicing. When I started practicing, it was like the last extreme. You tried everything else that you could before you went to IVF. It was this, final straw. And now people are a little bit more casual about it and actually jumping to it and assuming that we're going to do it a little bit quicker. But IVF is only as good as the eggs and sperm that we have to work with. It was, invented for people with blocked fallopian tubes. 41 years ago. It's a way to bypass fallopian tubes. It's great for male factor if someone has a low sperm count, but they still have sperm. We can really help the sperm fertilize eggs in the lab. But the final frontier is really eggs. So women with really poor egg quality or low ovarian reserve, sometimes they are very quick to want to do IVF and get very frustrated when I have to say, listen, the chances of this working are really, really low for you. It might take multiple cycles and, we can do everything that we can, but I got to be transparent and honest with you before we get started.
Yeah, I think that's really important to think about and to realize that there are cases where, IVF is not a fix-all for every fertility problem. So I do think it is definitely put on a pedestal in the fertility community. And I think people who haven't gone through infertility or, experienced any trouble conceiving at all, they kind of just think, well, why haven't you done IVF yet? They talk to somebody who's going through a fertility struggle and they're like, okay, so when are you starting IVF or why haven't you done it yet? This will get you a baby faster. Like, why wouldn't you do that? And there are some very real reasons that a couple might not want to do that, either because, they are struggling with egg quality or ovarian reserve, or just that they don't necessarily want to take on the financial burden or maybe even just the side effects. I mean, it's a tough procedure to go through. It's
Mhm.
not just like a piece of cake.
Right. Exactly.
Yeah,
Exactly.
I don't think people really understand it until until they're kind of knee deep in it. Like once they get all the stimulation and, you know, the other drugs and the multiple ultrasounds and all that. And
It's a big undertaking.
and then they're like, okay, well, I guess we're in it. Let's go.
I think it's something that you can't really prepare for either, because it's kind of unlike any medical treatment that you would have ever gone through before. So it's hard to know what it's going to be like until you actually go through and do it.
Right. And I'm trying to find ways to talk to people and my patients about it. There's so much, like, you're preparing for the meds and the appointments, and you're trying to continue your life, right? Like whether it's work or, you know, having children or going to school. And then on top of that, you're adding all of this other, you know, appointments and shots and calling insurance companies, and just the mental part is huge. The what if, and, you know, it takes up a lot of space and emotional energy.
Yeah.
Yeah, definitely true.
So we're going to move the conversation back to pregnancy loss, because that's kind of what we wanted to focus on since you wrote this amazing book. And the one thing I wanted to ask you about miscarriages. So if a woman has a miscarriage, which we know is very common, right? 1 out of 4 have it, especially when they know that they've had a positive pregnancy test. And so what is your suggestion? So if they come to you as a doctor and either they've had 1 or 2 or 3, like at what point do you start investigating other causes, and like what would be your first line test that you would start
Sure.
with?
So one clarification is, and I see this all the time on social media and in articles, people say 1 in 4, and they assume that means 1 in 4 women have had a miscarriage, but it's actually 1 in 4 pregnancies. So I would argue it's more than 1 in 4 women. And that's actually not really including biochemical miscarriages. And so if you include that,
That's higher.
it's basically everyone, right?
Mhm.
So anyway, I just think that's really important. And, you know, a lot of the fertility hashtags are 1 in 8, because it really is 1 in 8 couples in the United States meet the definition of infertility. But I just wanted to say, I think the 1 in 4 is really 1 in 4 pregnancies, because it's about a 25% miscarriage rate if you're in your 20s and 30s. And so I've really researched that, because I'm like, oh, is it 1 in 4? And when I'm doing posts, I'm like, hey, you know, I want to make sure that I'm giving out facts. So I think it might even be more than that.
Yeah.
And ASRM changed their definition and update to in 2013. That's the American Society of Reproductive Medicine, so it's our professional society, to say that it is okay and absolutely should be okay to start investigating if someone has had 2 clinical miscarriages. So they do clarify 2, but there are still lots of providers out there that don't start testing unless somebody's had 3 clinical miscarriages or later miscarriages. And that is because that's how I was taught in medical school, and how most of us were. It would only be anybody getting training after 2013 that would be really updated on that. They don't address biochemical miscarriages. So the way they define it is recurrent miscarriages are 2 or more clinical. Recurrent miscarriage is a disease separate from infertility that is defined as 2 or more clinical miscarriages. And a clinical miscarriage or pregnancy is defined as a pregnancy that you can see something on ultrasound or have a tissue diagnosis. So ASRM completely leaves out biochemical miscarriages, and the European Society of Reproductive Medicine came out with updated guidelines about a year or 2 ago that did say, hey, just so you know, there is some evidence that women with multiple biochemical miscarriages often also have issues that you can discover if you do an evaluation. So that is not going on in the United States, but you know, I do often do evaluations for women who've had multiple biochemical miscarriages, and you can find issues. So I know that's a long answer, but
No,
it's
that's great.
Great
because,
clarification. Yeah.
well, it's hard because, you know, patients will get a different answer from every medical provider that they go to, and that's because of where they trained or what they're reading, and that can just be really frustrating as a patient. But the testing, you know, you're basically testing the people that are getting pregnant to see if there's anything that you can do to intervene to decrease the risk of miscarriage. And just a reminder, most miscarriages is caused by the embryo. So that's why at least 50% of the time, and I would argue more, you don't find anything wrong, air quotes, when you do a recurrent miscarriage evaluation. But it's at its core, basically, it's a anatomy checkup. So you want to make sure that the inside of the uterine cavity doesn't have any fibroids or scarring or something that would impact implantation, like a septum, which is something that somebody can be born with. You look at hormonal issues like thyroid disease, prolactin. You screen for diabetes. We do one genetic test in both partners, something called a karyotype, which is a blood test that's looking for something very rare, but it's called a balanced translocation. And if that's found, that can put a couple at higher risk of miscarriages than you would expect for their age. And so anatomy, the one immune issue is something called antiphospholipid syndrome. So you're looking for a presence of antibodies in the system that really shouldn't be there when someone conceives, because they can affect the ability of the placenta to implant the way that it should. Immune, anatomy, hormones, genetics, and really that's it. That's the guidelines. I do also often do a semen analysis because these are couples that, especially if it's taking them a long time to conceive, or they're also thinking about doing fertility treatment. I want to get that as a baseline. And then something that I do, which is not a part of guidelines yet, but I do ovarian reserve testing on everybody that is coming to see me, partially because, again, they're thinking about doing fertility treatment. And if they have very poor ovarian reserve, they want to talk to me about IVF, I want to have a good conversation with them about the chances of success. But through doing this, over the past, several years, I really do and have found a high proportion of diminished ovarian reserve in my patients that have recurrent miscarriage. And so I think it's a reflection on, even at a young age, a higher percentage of eggs that aren't able to do all the chromosomal changes that they need to. So
Yeah. Yeah.
that's
Well,
important.
so let's kind of talk about that a little bit, because there are a lot of other recommendations in your book that you make aside from just talking about the treatments for each of these testing options that you just mentioned. You talk about ways that couples can make themselves healthier,
Mhm.
and that can kind of ultimately influence egg quality to some degree. So, talk about some of the recommendations that you make aside from just medical treatments in your book.
Absolutely. And that's one of my favorite things to talk about, because when you're trying to have your family, you feel so out of control, right? And a lot of times we don't find an answer. Like, we don't find a thyroid issue that I can prescribe a medication for. And so becoming healthier or looking at things that you can control can be very empowering for patients. So I think about, of course, smoking, heavy alcohol use, marijuana, managing stress. Like, we can't just eliminate stress. It's just like a misnomer. You can't be like, oh, I'm just not going to have any stress today. But if we can work on managing stress, I think it's helpful for us as human beings. I don't necessarily think that stress causes miscarriage, but if you are having multiple miscarriages, you are going to be stressed. And so why not work on that? And then I do a lot of talk and advocacy around environmental toxins and its impact on egg quality, sperm quality, and miscarriage risk. And I really opened my eyes to this as I was researching for the books. And when I first learned about all of this, it was very unsettling. And so you have to take it with a grain of salt and just sort of slowly take it in over time. But it's pretty disturbing just how overwhelming the evidence is that plastics, like BPA and phthalates, which are plasticizers as well, but also in a lot of our beauty products and home products, absolutely impact egg quality, sperm quality, and miscarriage rate. So I talk about just kind of taking it one product at a time, using apps like ewg.org or the Think Dirty app, where you can, just you running out of shampoo. Okay, great. Why don't you turn over the barcode and get your phone and check and see just how, toxic that shampoo is. Yeah, it's pretty toxic. All right, let's go find a new one. It's you can't just like go through your entire home, right? But trying to get plastic and heating up food kind of out of your kitchen. So if you have a plastic Tupperware and you're heating it up in the microwave, you're going to be getting toxins into that food. So I talk a lot about that.
Yeah, I think the toxins piece is really important. And it is super overwhelming when people first start investigating that. They're like, how is it possible that all of this stuff is in things that we use every day? Who's managing that? Who's protecting us? And the answer, unfortunately, is nobody yet. So I think the responsibility, unfortunately, is really on women and couples to do the research, and that's why it's so great that people like you and people like us are out there like spreading the word about how to get some of the stuff out of your daily routine. And thankfully, there are so many companies now that are producing cleaner personal care products, cleaner beauty products, better household cleaning products. It is possible for, an affordable price to replace some of these products with things that work just as well and that aren't going to harm you the same
Yeah.
way.
It's just awareness. And
Mhm.
I think something that's really important is if we educate people from a real fear, people are going to kind of shut down. Like if you think about
Mhm.
whole move towards climate change, like a lot of people are just like, I don't want to hear about it anymore. But something that's really positive, it's really only people with the highest levels of these in their system. Like if you do a blood test when someone has a positive pregnancy test, it's only this small portion of people that really have significantly high levels of BPA or phthalates in their system that have a significantly higher miscarriage rate. And there's lots of studies that show if you do make changes, your body recovers really
Mhm.
quickly. Like it's the scary thing, that 95% of Americans have BPA in their system, according to the CDC random check. That's scary. Like we are being exposed to them all the time, but little changes can drastically decrease the amount that is in your system. So that's very positive.
Yeah, definitely. I
Mhm.
find this very empowering. I mean, it's initially overwhelming, but it's empowering, especially in a case of recurrent pregnancy loss where you are looking to regain some semblance of control over the situation. And this is something that you do have control over. There are great options, and it can be done. And there are people out there that are helping to, spread the word and make it easier for couples to do that.
Absolutely. That's great. Exactly. I hope it's a positive message. Yeah, it's a couple of facts. Europe is so different from the United States. So United States, the last time legislature was passed to limit a chemical in a beauty product was in the 1930s. And think about how many different products have come on the market since then. A
Yeah.
total of 11 chemicals have been banned for use in the United States, and in Europe, it's over 1,500.
Yeah, they are definitely more on top of the research about how these things
Yeah,
affect us, and they are making changes. So, I mentioned earlier that I wanted to ask you about this, and we're getting towards the end, so I definitely want to cover it. But I wanted to talk about what women and couples should be looking for in their care team, especially if they're struggling with their fertility or they're looking for somebody to help them through recurrent pregnancy loss. What should they be looking for when it's time to choose a provider?
absolutely. I think there's got to be a connection or a feeling with the practice, and it can start with that very first visit where you just ask the question, "How am I going to get my questions answered?" And knowing that you're going to be able to communicate, get your questions answered, feel respected. And it also, part of it, there's a couple of things. Like if you're planning to do IVF, it is very important that you find a center that has good success rates and has a lab that is, you know, doing really, really well. I don't think in the lay public, people really realize how important the IVF lab is for success. And so that is a big part of it. But then if you're looking for care for recurrent pregnancy loss, that doesn't necessarily have to involve IVF. And it's an ongoing process. So you want to look for somebody that is going to be compassionate, and ask the question, when I have a positive pregnancy test, like, what are we going to do? Are you going to be like a previous provider that won't see me until I'm 10 or 12 weeks along? Because you know what? I've lost every pregnancy between 6 and 8 weeks. Like, will you see me early? Like, if that's going to make me feel better, will you see me early? And kind of have somebody that's going to be on your team answering questions, seeing you if you need it, not validating your concerns, right? Like going to a place where the team, because a lot of times you're not necessarily talking to the doctor every time that you call in, right? But finding a place where you feel that compassion and care is really important.
Yeah, I think that's really great advice. And, unfortunately, there are a lot of women and couples that have not had that experience with their care providers and they get, a little discouraged. And, it's just so great to know that there are a lot of providers, like really amazing doctors that are doing exactly what you just said, providing compassionate care, answering questions, making themselves available. So they're out there. You just got to find them.
Yeah, that's great. Well, and a lot of people really, I like the team approach. So looking for naturopathic doctors or nutritionists or even Eastern medicine doctors. And, the Western doctors like me, like I can do the tests and I can order, an evaluation and I can do IVF, but a lot of other things can kind of come together to really help the person in an integrative approach. So because sometimes access to care is really frustrating for people. So they're like, oh my gosh, I get DMs, all the time on Instagram. Can I see you for a second opinion? I live across the country, and I really have to decline because it's such an ongoing care. I can't fix everything with a phone call. And so, maybe finding somebody that can do the testing, and if that person you don't connect with them, but you're going to try naturally find that person that's going to be on your team. It breaks my heart how many women out there might have stopped trying because they gave up hope or they didn't find anybody that could support them when they didn't give up wanting to be a mom.
Yeah, definitely.
That's
So, well, I think the last question we have that we like to ask all of our podcast guests is, what is your pearl of wisdom that you want women to walk away from this episode with?
Oh, I love it. Be an advocate for your own care. There's a balance between reading too much on Dr. Google, but finding podcasts like this with compassionate people that are trying to get a positive and accurate message out there is really important. Finding books, like mine, asking questions and, going to appointments, researching a little bit is really, really helpful. And, finding a doctor that's going to take the time to answer those questions and be a partner in your care is really important.
Fabulous message.
Yeah, that's great
Yeah.
advice. Well, thank you so much, Dr. Shahine, for being here on the Mastering Your Fertility podcast. And can you just tell the listeners where they can find you? I know you're really active on social media. You've mentioned it a couple of times. And so just let us know where they can follow you.
No, thanks. Well, it's really an honor to be on here. Thank you. And my handle is the same across Instagram, Facebook, and Twitter. It's all Dr. Lora Shahine. And I do have a website where I kind of keep track of blog posts if it's something that I really want to talk about and feel passionately about. And you can reach me there.
All right. We will definitely make sure to link to those in the show notes. And thanks so much again for being with us. Have a great rest of your day.
Thank you.